Good afternoon. How you guys doing? Surviving? Can you hear me back there? I'm not going to use the mic, right?
That's cool.
Is that good?
Yeah, sure.
All right. Glad to be back.
Welcome back.
Thank you. So today we're going to talk about dialysis and drug dosing in dialysis. I think this is a cool topic in that, as a pharmacist, you're going to come across many, many patients who are on dialysis, whether it's in the outpatient setting or in the hospital in the acute care setting, or maybe even the ICU. So it's a very important skill to learn on how to dose drugs in dialysis. So I'm going to talk a little bit about concepts and kind of tell you how I do it, how I approach a patient who is on dialysis. There's many, many ways to do it. But hopefully after this, you'll have some idea of, again, how to approach that patient whenever you see someone who is being dialyzed, whether it's acute or chronic. How many of you know someone who's on dialysis? Yeah, it's fairly common, right? I mean, it's and really, as you guys learned this week, like those patients who are on dialysis, they're on many, many different drugs, right? To treat whatever the reason that they start on dialysis or initiated on dialysis. So it's important to know, how to identify those drugs that are affected by dialysis. So for my portion of this lecture and the exam, make sure you're familiar with these learning objectives, okay? The questions that you'll see on the exam will be based off of the learning objectives. I don't think that my material, so this lecture will be on the case application. So it's just going to be on the exam, okay? So hemodialysis is initiated based on when patients have a low GFR, right? A low creatinine clearance, and they cannot filter all the toxins that your kidney does and provides. So it is based on that low GFR, but also on signs and symptoms of kidney failure, which I hope you've learned some of those signs and symptoms of kidney failure by now. So throw out one sign and symptom of kidney failure.
So increase urine output.
Decrease urine output. Awesome. Edema, volume overload, right? Your kidneys are vital with regulating the volume in the body. So if your kidneys are dysfunctional or they fail, you're not going to be able to regulate volume in your body. So you can't get rid of volume. So your kidneys are very important on doing that. So dialysis will remove all these waste products that happen with metabolism, right? So the food you ingest or whatever you drink, all that stuff has to be metabolized. And there's waste products that come out because of that. So your kidney is responsible for removing all those soluble waste products and then regulating that fluid balance. Some kind of definitions, CKD stage 5 is typically defined as a GFR less than 15. And that's kind of the threshold on when someone may need dialysis. So if their GFR is less than 15, all those waste products are going to build up. The fluid is going to tend to build up, and they are more likely to need dialysis than someone who has a GFR greater than 15. Hemodialysis, it is a life-sustaining treatment, right? Without your kidneys, without dialysis, those patients have serious consequences, and they can have arrhythmias because they increase hyperkalemia. They can have fluid overloaded and all the issues that arise with that. So without helping them filter the blood and regulate fluid, they may die. So it is certainly a life-saving treatment. So the goals in hemodialysis are to remove those waste products, right? To eliminate the toxins and urea that build up from metabolism. Regulate fluid balance, like we said. Correct any type of electrolyte abnormality, specifically hyperkalemia. I think that's one of the most important electrolytes when you're dealing with renal insufficiency or renal failure. Maintain acid-base balance, like we mentioned about a week ago. So your kidneys are very responsible for maintaining bicarbonate and regenerating bicarbonate. And if your kidneys are dysfunctional, your bicarbonate may be low in that patient, which will provide what kind of acid-base disorder if you have low bicarbonate? Right on. It will help support blood pressure, right? Your kidneys are responsible for helping support blood pressure, as we learned. So all these goals are important in dialysis. So how does it work? I'm going to go through a couple pictures of how dialysis works. And what I'll do probably tonight or tomorrow is put up some like YouTube videos as well that show you in a video format how dialysis works. I wanted to do it last night, but we had all the internet issues, and so I couldn't upload it last night. But I'll do that tonight or tomorrow. But in simple word form, blood is drawn from the body via an access point. So we're going to talk about the different access points, but basically you take the blood from the body and you put it into the machine, and within that dialysis machine, there's a semi-permeable membrane in that machine. So think of it as a filter, okay? It filters your blood, and it will filter out all the waste products. It will filter out some of the fluid. So that is removed through the dialysate, the fluid that is that contains all the waste products and the extra fluid. That's called the dialysate. That is discarded, and then the blood is returned back to the body. Sounds pretty simple, right? So what are indications for dialysis? This is an important slide. One way to remember these indications is A, E, I, O, U. So the vowels, basically, A, E, I, O, U, right? A stands for acidosis. So if you have someone with severe acidosis, dialysis can control that acidosis and correct that acidosis. And we do that by providing a base in the dialysate fluid, in the fluid that is filtering the blood. So that base will correct the acidosis. And you can pull off substances that cause acidosis as well. Electrolyte imbalance, again, like hyperkalemia, right? In that end-stage renal patient who misses dialysis and they present with signs and symptoms of hyperkalemia, peak T waves, et cetera. One of the most important things in that patient is to get rid of the potassium. So eliminate the potassium. So that would be here, electrolyte imbalance. Next is intoxication clearance. So this is mainly seen in like toxicology. So some substances where whether it's drugs or chemicals that people ingest and overdose on, et cetera, those can be, not all, but some can be removed by dialysis. So that would be a form of treatment with an overdose patient or a patient who ingested something that is going to be removed by dialysis. So that would be one indication. Fluid overload, that's a perfect indication, right? We talked a lot about fluid in congestive heart failure. And if you can't diurese the patient because their kidneys aren't working, you can certainly remove some of the fluid through dialysis. So that is another very common reason for dialysis. And then probably one of the least common is uremia symptoms. So your kidneys filter urea, right? Blood, urine, nitrogen. So when someone presents with a very high level of BUN or uremia, they can present with encephalopathy, some pericarditis, neuropathy, etc. And then you can treat the patient by dialyzing the patient to remove all that uremia from the blood. That's probably the least common indication up here. But all these indications are fair game. So an easy way to remember it is AEIOU, okay? It's an important slide.
Dr. Gonzalez?
Yes.
So there are multiple electrolyte imbalances. Are we assuming we're focusing on hyperkalemia because it's more common, because it's more severe, or a combination of both?
Great question. So why didn't I mention the other electrolyte abnormalities, basically, right? Is that kind of getting towards your question? Remember, with hyperphosphatemia, we have some other things that we can use, binders and things like that. It's very uncommon to present with a severely high phosphate to cause issues. It's not uncommon to present with a severely high potassium, and that will cause issues like we learned, right? With all those EKG changes and things like that. So it's those electrolytes which will cause basically life-threatening conditions. So potassium is one of the most important ones as far as renal insufficiency and things like that. But you can present with like fluid overload and hyponatremia and things, certainly with that nature. In that patient, they would fall under here as well as electrolyte, but you're removing the fluid to treat that situation more than the electrolyte. That was a great question. Mechanisms of dialysis, okay? We're going to talk about a couple mechanisms of dialysis. The first one is diffusion. You guys should know about diffusion from our volume lecture. So diffusion is a movement of solutes across the semi-permeable membrane, right? It happens in the cells in the body, but it also happens in that filter, that dialysis filter. That is a semi-permeable membrane. So we'll see diffusion of solutes over time across this semi-permeable membrane. So remember, it goes from a high gradient to a low gradient. So that's always going to occur if that membrane is permeable. So your solutes over time will equilibrize between those two compartments. It is the main mechanism for removing the small molecules, water-soluble molecules, and non-protein bound drugs. The efficiency of diffusion will depend on the size, the molecular size. So the smaller the size of the solute or the drug, the more efficient it's going to move across that membrane. It's going to depend on the concentration gradient. If there's a high gradient, it's going to be more likely to promote diffusion, right? Because of that gradient, concentration gradient effect. And then the membrane size itself. So this semi-permeable membrane, or the filter of the dialysis, comes in many different sizes. And so that the function of that filter will determine how well diffusion occurs. And then also it's dependent on blood flow in the filter and the dialysate through the filter, which I'll show you a picture of. So that's one important part and method of dialysis. Any questions on diffusion? So ultrafiltration is really the movement of water or fluid that happens through dialysis. But it is from a pressure gradient. So with ultrafiltration, you have pressure pushing the fluid through the membrane, okay? So ultrafiltration is really focused on the fluid going through the membrane, and it's enhanced by the pressure. So the more pressure that's being put on that filter, the more fluid that's going to go across that membrane. Does that make sense? So it's used in like fluid overload patients where you want to pull a lot of fluid fast to help that patient compensate for that fluid overload. So it will help maintain fluid balance, but the factors that affect ultrafiltration are that transmembrane pressure. So the higher the pressure, the more efficient the fluid will go out. Certainly the membrane permeability, because the membrane has to be permeable to that fluid. That makes sense, I hope. And then the duration of dialysis. So the longer you do it, the more efficient it's going to be. And the flow rate, how fast it's going. So ultrafiltration is important when we talk about convection. So convection is the second method to remove solute. So the first method is diffusion. Second method is convection. So convection is a process of moving solute by that fluid movement, by that ultrafiltration, okay? So convection uses ultrafiltration to move the fluid, but also the solute. Does that make sense? So we're talking about the two different forms of dialysis or methods of dialysis. One is diffusion, one is convection. And they both remove solute. Diffusion removes it by the concentration gradient. Convection will remove it based on that pressure gradient through ultrafiltration. So convection depends on the same things almost as ultrafiltration. So molecular size, higher rates of ultrafiltration, so the more pressure will push more fluid, and with that fluid will push more solute. And then the membrane pore size. So how big those pores are in the membrane. So again, the pressure is pushing down. You're seeing fluid move over here with the blue arrows, and then the solute is coming in with that fluid. Question?
I have a question, but dialysis in general, so maybe when you finish.
Okay. Any questions on convection? Which one of these processes can remove more solute? Good. All right. Which of the following best describes diffusion in hemodialysis? A, movement of solutes across the membrane driven by pressure. B, movement of water across the membrane due to osmotic forces. C, movement of solutes from high to low concentration across the semi-permeable membrane. C, excellent. What types of solutes are primarily removed by diffusion during dialysis? How many?
Small molecule.
Everyone agrees on C? Good. The small molecules, right? It's not going to remove protein-bound molecules. Diffusion isn't. Middle molecules, not as affected by diffusion. Small molecules definitely are affected by diffusion. What about this? Why isn't this correct?
Because they're going to have H. They're not water soluble.
Good. So where, if it's not water soluble, where is the substance?
They would have to be like, what do you call emulsified or something like that.
Well, it's in throughout the body, right? Yeah. So if it's water soluble, it's more likely to be in the blood, right? And that's exactly what we're filtering with dialysis. It's the blood. That's the only thing we're filtering with dialysis. So you're taking the blood from the patient, putting it in this filter. And so if the lipid soluble vitamin or drug is more in the body rather than the blood, it's not going to be readily dialyzed off. Does that make sense? All right, convection in dialysis best described as a lot of B's. So solute transport driven by solvent drag during ultrafiltration. So remember, convection uses ultrafiltration. Ultrafiltration is a movement of fluid when you apply pressure. So with that fluid, solutes are going to come with that fluid. And that's a solvent drag, okay? A is diffusion. This has nothing to do with it. Gases we don't care about right now. That's just outright wrong. Which of the following is not one of the classic A, E, I, O, U indications for initiating dialysis?
Urinary retention.
Oh,
Over
it's
there.
urinary.
Urinary retention.
Yeah.
All right. So acid-base disorders, clearly, yes, right? A is for acidosis. E, electrolyte, we said refractory hyperkalemia is one of the most common. Intoxications, lithium overdose. As you will know very soon, lithium is water soluble. It's going to be readily dialyzable off. Fluid overload is certainly one of the indications for dialysis. Urinary retention is not. What does U stand for? Uremia. Okay? Know this. A-E-I-O-U. It will be on an exam shortly. I haven't written it yet, but as soon as I write it, it'll be on the exam. So you guys want to be able to compare diffusion and convection, okay? I might ask you a question on the differences between convection and diffusion. So know these two concepts. These are important concepts for dialysis. Modes of dialysis. So today we're going to talk about hemodialysis, continuous renal replacement therapy, which is a form of hemodialysis, and then peritoneal dialysis, which is totally different than hemodialysis. Hemodialysis is what you guys are probably most familiar with. So if a patient is on hemodialysis, they are more likely to go to a center nowadays to be dialyzed, usually 3 to 4 times a week. So they have to go to a center, get dialyzed for a session. It takes about 4 hours to hook them up to the dialysis. clean the blood, and then, let them go. So they do that 3 to 4 times a week. For continuous renal replacement therapy, this is what we do mainly in the ICU. So it's when someone can't tolerate regular hemodialysis, and we'll get into why. So it's very common in the ICU setting. And then peritoneal dialysis is one of the oldest forms of dialysis. Not as common as hemodialysis, but still used today. Okay, so we'll talk about all 3 of these. So hemodialysis first occurred in the 1940s, so quite a while ago now. And permanent dialysis access started around the 1960s. So, they were in about 20-year period, they were trying to refine the process and then finally developed a way to have a patient have permanent access so they can be dialyzed. That's important. So after that, routine dialysis started to occur in patients who needed dialysis. And it's really the most common form of dialysis today. And it's based on diffusion, okay? Hemodialysis, based on diffusion. You can have very rapid metabolic clearance, so clearing all those toxins in that, 3 to 4 hour session. And then removing fluid as well, okay? So this is kind of a schematic of what happens when a patient is dialyzed. So you have the blood coming from the patient here. So out of the patient, there's a pressure, like almost a blood pressure gauge, thank you, and a pump. So you need to pump the blood out of the patient, and then it goes into the filter. So think of this as a filter. It's a dialyzer. That's what has a semi-permeable membrane, okay? Within that filter, it's going to allow the blood to go through here, and then it's going to use fluid to create a concentration gradient. So the blood is going to go up, the fluid is going to come down, so they're going in different directions, right? So the blood's going up, fluid's coming down, and that's going to create that concentration gradient. So in this fluid is a bunch of things, but it's mostly basically, it doesn't have any urea, of course. It has some sodium, some potassium, etc., depending on the patient, and you can personalize the fluid. But it's going to assimilate the normal concentrations of blood, generally. So if there's a high level of potassium here and not here, potassium is going to go across that semi-permeable membrane. Does that make sense? If there's a high concentration of urea in the blood, there's no urea here, that urea is going to go across the semi-permeable membrane. So the fluid that comes out is a dialysate. This is all the toxins, all the electrolytes that you don't need. And then the blood goes back, the filtered blood goes back to the patient.
For how many hours the patient needs to last?
About 3 to 4.
And that hurts, like.
No, that's a great question. It doesn't hurt. So I have in a couple slides we talk about access. So they have ports or a graft or a catheter where they just hook up the IV catheters. So they should have, in most cases, they should have a permanent port or a graft. Great question though. So so being dialyzed after you have that access should not hurt. There's some complications that can arise, but it shouldn't be painful per se. Any questions on this diagram?
Is the gradient sideways in that diagram? Sideways? or would it be like through the column?
So it's within this column, but your blood's going here, and then the fluid is coming down. So it's going to be this way. And those videos that I'm going to share, I think it'll show you in a animated version of it, so you should be able to see it coming through and appreciate it better, maybe.
Question. So the dialysis, what they should take it after?
What happens in dialysate?
Yeah. Trash?
Trash. Not regular normal trash because it's biohazard, but it's discarded. So we're going to talk about 3 forms of access. So AV fistula. So you go from an artery to venous and have a fistula there. An AV graft. So it's a synthetic graft that transverses artery and venous, or just a central venous catheter. So those are the 3 main types of vascular access. Now within these access, you can have infection, thrombosis, so that graft or the fistula can be have thrombosis. And then you can also have inadequate dialysis, which is probably the main cause of that is slower blood flow. So the risk increases as you go down. So central venous catheter has a higher risk of infection, higher risk of thrombosis, and potentially inadequate dialysis, okay? So the AV fistula is over here. It shows you on the picture over here. So it's just a fistula between the venous side and the artery, and then the catheter is into that fistula right here. Okay. This is probably one of the most common forms of access. Certainly the patient needs surgery to have this access. It's good for long-term access. So patients with chronic kidney disease who are reliant on dialysis will either have a fistula or a graft. And it requires about 6 to 12 weeks for that fistula to mature after surgery. So you can't use it until the fistula is mature. So that's important because if the patient needs emergent dialysis and they go in for this fistula, you're not going to be able to dialyze off of that fistula. Some patients fail to mature, so it just won't mature, and they'll have to try another site. So it's not suitable for all patients, but it has the lowest infectious and thrombosis risk, okay? The graft is a synthetic tube that connects the artery to the venous side. So they're using a synthetic tube to do that instead of a fistula. This is ready to use in 2 to 3 weeks, so it doesn't take as long to mature because of that synthetic tube and because of the procedure that they do. It can be used in patients with poor veins, so whereas a fistula is less likely in patients with poor veins, but it has a higher infection risk than the fistula. And it requires more interventions to maintain the patency, the opening of the tube. Central venous catheter is the one that is used for short-term dialysis or immediate dialysis. So if you have a patient who is not being dialyzed, they come in the hospital and they need dialysis, this is what they're going to get, okay? This is something that they could do in the ED, in the ICU, very quick, get access, hook them up to dialysis. So it can be used for immediate dialysis. You don't have to wait for it to mature or anything. It's the last line for hemodialysis access because it has the highest risk of thrombosis and infection. It's not a permanent method for dialysis, okay? It's only a short-term method for dialysis. And it tends to have a lower dialysis efficiency. You're going up here in the neck, more, most commonly. You can do other sites, but up here in the neck, you're getting the catheter, and it just, the flow rates aren't as good. So generally, lower dialysis efficacy.
So for patients who go for dialysis on a weekly basis,
Yes.
which of them?
If the patient is going for dialysis on a weekly basis, so they're going to get a fistula or a graft. Not this. This is done generally in the hospital for immediate dialysis. Okay, so this.
One question, bro.
Yep.
You said the graft is, or is it the fistula? Yeah, the fistula is prone to infection. Risk of infection with the fistula.
Yes.
So how would it be overcome?
How would you overcome it?
Do they
Proper skin care and things like that. That's the best thing. I mean, besides a surgical procedure, hopefully it's a good surgical procedure. After that, proper skin care. That's the most.
If it gets infected, they have to take them off and put new ones? Or what?
It all depends. It's a case-by-case basis. But they may have to take it out and replace it. Yes. Yep. So the dialysis procedure. So this shows you the filter a little bit better. So again, you have the blood from the patient going here, coming down in this picture. You see this? This is based on your question here. So the blood's coming down, and the dialysate in this case is going up, and the fluid's going out. So the blood's coming down, and it's creating that concentration gradient. They saw that semi-permeable membrane. So solutes are going out, fluid is going out, and into the dialysate or the effluent. So this shows it a little bit better. But again, I'm gonna show a video tonight or tomorrow. Any questions on this?
Those pumps, like they are squeezing the tube to take out the how they work.
Yes, it's basically has a mechanism that is creating, I guess not a vacuum, but pressure.
Is it peristaltic?
Peristaltic. Yes, that's it. Thank you. But it's much bigger than like a peristaltic pump that for like an IV. And then this is another picture. So I wanted to show many different pictures of this so you guys can appreciate what's going on. So in this case, the blood is coming in the orange over here on the left side, coming down. Dialysate is going up, and it's creating that concentration gradient, okay? And things that will improve the fusion is the permeability of this membrane, how fast the fluid is coming, both fluids. The faster, the more the concentration gradient is. So those are the main things that are going to affect it. And then the holes of the membrane.
How aligned is that with the physiology of the loop of Henle? Is it that design is pretty similar, right? In terms of like the counter current that you have in the
Yeah, I mean, it creates, there's a lot of more like active processes and things like that, right? With all the pumps, the sodium, potassium pumps, which this is just diffusion, but yeah. All right, so complications. Infection is a big complication of dialysis. Risk is due to vascular access, which has the highest form of infection of the access.
The cat, direct.
Yep. Okay, know that. Okay. Prevention is strict hygiene, proper access care. So going back to your question, that's the biggest thing the patient can do to prevent infection. It can cause hypotension because you're removing blood from the body and fluid from the body. Okay. So some patients may not be able to tolerate the dialysis session. They might have to slow the rate of fluid removal to prevent hypotension. But this is one of the main causes of the complications in dialysis patients is that hypotension. I'm not going to talk about treatment of that. This is not for this lecture. But just know that hypotension is one of the main causes, complications. It can certainly cause electrolyte imbalances. Like you can overdialyze someone's potassium and cause them to be hypokalemic. And other electrolytes. You can have dialysis disequilibrium syndrome, and that's just a rapid shift in fluid and solids during dialysis. And then there's things to do with that. Muscle cramps, anemia, skin issues. So this is mainly just for your own knowledge, with the exception of infection and hypotension, okay? So continuous renal replacement therapy is a different form of hemodialysis. So you still are using the blood, you're still using a filter to dialyze the patient, although in this case it's continuous. So the other one was intermittent, right? They're doing it 3 to 4 times a week, 3 to 4 hours a session. This one is 24 hours a day. So this developed in the late 70s, and it was really designed for the ICU patient to dialyze those patients who were hemodynamically unstable to be dialyzed with the regular intermittent dialysis. So this one is continuous, so you don't have as many fluid shifts. It's a little bit easier to maintain fluid balance in that type of situation where you're just continually pulling off fluid and solute. In CRRT, it can use diffusion or convection or both, okay? So we have many different types. In regular hemodialysis, it's just diffusion. CRRT, it can be either one or both. And again, it operates 24 hours a day. It's continuous. Benefits to maintain hemodynamic instability or stability, allows precise fluid management, and then supports multi-organ function. So we have 3 main modalities, and there's more than this, but this is the ones that we're going to talk about today. CVVH, CVVHD, and CVVHDF. So what's the C stand for? What's the VV stand for? Someone said vein. Who said vein? You're right. It's venous. So there's also CAV, arteriovenous, but this is CVV. You're going to go into critical care. Okay, so in this example, it's just VV. So it's venous blood. And then H is convection. HD, think of D for diffusion. And then HDF is a combination of convection and diffusion. Okay? For CVVH, you use a replacement fluid. It has electrolytes, again, similar to the regular dialysis fluid. It simulates normal electrolyte, serum electrolytes. CVHD, you have a dialysate that has different amounts of fluid. And then in convection or CVHDF, you have dialysate and replacement fluid. You don't need to know that part. For CVVH, it's good for middle-sized molecules because of the convection, because of that pressure gradient that you're creating. You're going to be able to pull off larger molecules than diffusion, okay? That's an important characteristic. So with convection, you're able to pull off larger molecules. With diffusion, it's going to be the same as hemodialysis that we just talked about. So it's usually only good for those smaller type molecules. And then convection and diffusion, both. That makes sense, I hope. So similar setup over here. You have diffusion on the left and then convection on the right. So you have from the patient blood with a pump going into this filter, but in this filter you have a pressure gradient in convection. And then post-filter replacement fluids over here to replace some of the fluid and electrolytes that is lost in the dialysate. So just remember with convection, it uses that pressure. It's going to pull off more fluid and more solute in small to middle weight solid. So comparison between CRRT and hemodialysis, again, the timing, so CRT is continuous based on the naming, the type of population, certainly more critically ill patients with CRT, whereas hemodialysis would be outpatient or inpatient dialysis. Hemodynamic stability, so the continuous is used in those hemodynamically unstable patients, so they have low blood pressure or they may be in shock. So you can't use regular hemodialysis because that's taken off too much fluid. There's too many shifts there. So continuous, it's much easier to maintain that intravascular volume. Solute removal is diffusion and or convection. Whereas hemodialysis is just diffusion. Those are the main differences there. Peritoneal dialysis. Peritoneal dialysis, I mentioned, was one of the earliest forms of dialysis. So developed in the 1700s and still used today. It's kind of cool. It uses the peritoneal membrane. So the patient's own peritoneal membrane to create that diffusion and to filter the blood. So what happens is a patient has a catheter that is surgically placed in the abdomen, and then you have a dialysate fluid that is infused in the peritoneal cavity. So that fluid creates that concentration gradient. So in the blood, in the patient's blood, you have all those solutes, all that toxin, and then by applying this dialysate in the cavity, that will create the concentration gradient. So the patient uses their peritoneal membrane for that gradient. And then you get rid of that dialysate after a period of time. So here's a picture of it. So you have a catheter placed right here. And then you have this dialysis solution that's instilled in the peritoneum. And then it just sits there for a period of time. It depends on the type of dialysate. But it sits there for a period of time. Then after that time, you remove that fluid. So what is happening is this dialysate fluid, again, creates that concentration gradient. So by diffusion, you're going to leach out the toxins from the blood and electrolytes into that fluid. and then you take the fluid out.
The fluid does not diffuse into the body.
Some does, yes. Some will. This is a different picture of it. So you have the fill of the fluid here, and then the dwell time. So you just let the fluid sit there in the cavity of the peritoneum, and then you discard it, drain it out. So this is done. The patient doesn't have to go to a center to do this. This is an advantage of peritoneal dialysis, so they could do it at home. It can be done 3 to 5 times a day where they're instilling the fluid, letting it sit there, and then dumping it out. No machine is required, right? Because you're just using fluid bags to put it in and drain it out. And it certainly will allow normal daily activities during dialysis. So you can be mobile while you have the fluid in there and it's doing its thing. Then you go home and drain it out. So offers a lot of mobility and can improve quality of life because of that. The other one is automated peritoneal dialysis. So that uses a machine to do the exchange at nighttime. So what happens is a patient has a machine here with the dialysate hooked up, and then they'll infuse it overnight and take it out overnight. So in the morning, they're good to go. So that is another way you can do it, is during the night with the machine. Advantages, it can be performed at home. It offers greater dependence because you don't have to go to that dialysis center. It's generally considered to be gentler on the body because you don't have those huge fluid shifts that you would see in dialysis, hemodialysis. Biggest risk is peritonitis. So again, you have this catheter in the peritoneum, and any foreign catheter or body and an object inside the body increases the risk of infection, right? So they have to maintain that catheter well. So risk of peritonitis is there. It certainly needs some manual dexterity to manipulate all the catheters themselves because they're doing that themselves. And then certainly clean technique. You want to make sure you use aseptic technique as much as possible. And then maybe less effective in patients with abdominal scarring because they're not going to have that diffusion as much, or if they have a large body size. So you should be aware of some of the differences between peritoneal dialysis and hemodialysis that are listed on the slide. It's a nice summary. And I think this is a good time for a break. Take a 5-minute break.
Goes into the navel?
No, in the abdomen, not the navel. Just like on the other side.
But it doesn't.
I mean, they use anesthesia to put in the catheter. So once the catheter is in, it shouldn't hurt. You may feel discomfort with that fluid. It makes you feel cold. But over time, it should
It's okay.
even with the cartoon.
Yes.
Yes.
Yeah.
Okay.
I mean,
So you may not go into it.
yeah, I know. Definitely. Well, I would like to try it, but at the same time, like, that's also why, I guess, career pathways wise,
it's general, or, you know, to be in the nursing home and be on that side. I became when I was
Get used to it too.
I know.
You can. So
I can't. I'm okay with life. Other people like that's what happened to me when we were doing immunizations. The person that I was immunizing, when I let out the needle, was like,
sounds like
yeah.
Just that.
I'm like, but
Is that weird? What you it's just
it feels weird and it's like I'm feeling a little some way. I don't know why. I don't know. It's a what do you call it? A visceral reaction. I was just curious.
sí.
Que no va a llegar un kilo. Aquí, o sea, utiliza los caps de lado. Los rojos, eso yo utilicé como la base. No me quedó, pero yo soy que sí. En Amazon lo vi.
Dr. Gonzalez, can you tell us where to focus on this slide? It's too much. You know, like only in the objective where. Okay. For example, in this like tables like this, do you know what those techniques or
Well, this is a summary of what we've talked about, right? So I think it's so general differences, maybe general advantages. That's I think that's very. But certainly, what I want you guys to know is what is diffusion, what is convection, and what dialysis, most dialysis use convection versus diffusion. That's important, right? And then we're going to talk a little more broader concepts about what properties will allow a drug to be dialyzed. I think that's very important as pharmacists. So we'll talk about those things.
Perfect, thank you. I mean, Dr. Gonzalez, based on which one is that? It's not smoking without. Which one is the best for the
Yeah, I would say analysis. It's more efficient. She says so as long as it's
Quiero también hacer ejercicio para no estar tan cansado y con el tiempo.
I heal. Superpower. Yeah, I don't yeah, I would say actually, right now, I just need some recent surgery is coming out. I think so.
All right, let's talk about drug dosing in dialysis. So certainly dialysis will affect drug elimination, right? It will affect all the potential drugs in the bloodstream the most. Hemodialysis and peritoneal dialysis will differ in the ability to remove drugs based on the type of dialysis, the membrane type, and duration of dialysis. Continuous renal replacement therapy will provide a slow, continuous clearance affecting both hydrophilic and protein-bound drugs to some extent.
So if you have like a drug that is highly protein bound, you cannot. Do you wait for like in time so you can remove it, or what do you do for?
So we're going to talk about factors that influence drug removal through dialysis. So the drug-related factors are molecular weight, protein binding, and volume of distribution, or degree of lipophilicity. Patient-related factors are albumin. So generally, I think you probably learned by now that most chronic kidney disease patients have a lower albumin. Fluid status in that patient. So are they hypovolemic, hypervolemic, blood pressure? Dialysis-related factors are the type of dialysis, so whether it's hemodialysis, CRRT, or peritoneal dialysis. Prescription of dialysis, which is generally the membrane that they use, the flow rate that they use, the duration that they use, those are all the prescription. Conventional versus high flux membranes. So the technology of the filters or the membranes that they use now is totally different than 10 to 20 years ago. So these filters are more efficient at removing solute. And certainly there's what's called high flux membranes, which remove a lot more substances than the conventional ones. The membrane type, cellulose, which is older technology, versus the newer semi-synthetic or synthetic membranes, which are used now more predominantly, and then the blood and dialysate flow rates, and then the overall length of dialysis. So the three factors: drug, patient, and dialysis. So drug removal by dialysis is increased if the drug itself has a small molecular weight. So the smaller the molecular weight, the easier it is to pass through that semipermeable membrane. If it's low protein binding, right? So if it's highly protein bound, what proteins are we talking about? Albumin and what else? What's another main protein that drugs bind to? Alpha-1 acid glycoprotein. Have you heard of that? Maybe, maybe not. So the two main proteins would be albumin and alpha-1 acid glycoprotein, okay? Those proteins generally aren't going to pass through that semipermeable membrane. So if it's in the blood and is bound to that protein, it's not going to be dialyzed or pushed through that semipermeable membrane. Small volume of distribution drugs, so low lipophilic drugs, we already said if it's lipophilic, it's more likely to be outside the intravascular volume, right? In the lipid stores, et cetera, skeletal muscle. So small volume distribution drugs are more likely to be in the intravascular, in the blood, basically. So the more likelihood that the drug is in the blood via low volume distribution, the more likelihood that the drug is going to be dialyzed. That should make sense based on the fact that we're taking the blood from the patient, hooking it up to the filter, and then dialyzing the blood out, right? So if it's not in the blood, or the majority of the drug is not in the blood, it's not going to be pulled off to a great extent.
Prof, that means the time that the drug was taken would also be a factor?
The time, definitely, and that's a dialysis related factor. But if the majority of the drug is inside the lipid stores and et cetera, you're going to have less efficient dialysing, right?
When I was talking about time, that it takes time for that distribution to happen. So if, for instance, the medication is taken now, and immediately the patient is going for dialysis, we expect a lot of it to still be in the blood, compared to maybe a medication the patient took in the morning, and it's going for dialysis in the afternoon.
Yeah. So it depends on how much is in the blood. So whether based on absorption and things like that, those characteristics, right? Yes. High flux dialysis, like I mentioned, that's a dialysis related factor. So if you read that the study uses a high flux membrane, that is going to pull off the most solute, the most drug than the other membranes. Semi-synthetic and synthetic dialysis membranes will pull off the second most after high flux. The flow rate of the dialysis, the higher the flow rate, the more solute, the more drug is going to be able to be pulled off. All right, so this is an important slide. You need to know the drug-related factors. We're going to have a couple slides on those. You need to know the types of dialysis-related factors, like the high flux, conventional, membrane type, et cetera. So as far as molecular weight, this is typically measured in Daltons, right? You guys learned this probably in P1, I think. It influences how easily the drug passes through that semi-permeable membrane. Low molecular weight drugs with a Dalton of less than 500 are easily passed through that membrane. In all membranes, it doesn't matter what the membrane is. Moderate or middle-sized molecular weight drugs, 500 to roughly 20,000. This is not a hard cutoff. Could be slightly higher than that. Tend to be pulled off more so depending on the membrane type. So if it's a high flux membrane, that's going to pull off some of these larger molecules, the high flux membrane. If it's a semi-synthetic membrane, it's probably not going to go up to 20,000. It may go from 500 to like 5,000. So not as much, but the high flux will definitely pull off larger molecules. That's important. High molecular weight drugs are generally not removed by dialysis. So above 20,000, 30,000, 40,000, they're generally not going to be removed, especially if it's protein bound, right? So this is an important concept. So the size of the drug, the smaller, the more readily you're going to be able to dialyze it off. The more readily that drug is going to go across that semi-permeable membrane. This shows you some examples of small molecular weight. So potassium is only 31 Daltons, very small, very easily dialyzed off. Urea is 60 Daltons. Cefepime and some of the other cephalosporins, only 500 Daltons. Those are going to be pulled off by regular dialysis, certainly with diffusion. With convection and using the high flux membranes, you can pull off some of the middle weight or moderate molecular weight substances. So vancomycin, 20 years ago, it wasn't as readily removed. But with new technology of those filters, it's more easily removed. And then all the way up to like, 12,000 Daltons there. Albumin, rituximab, things like that. Look at rituximab's molecular weight. It's very, very high. That's not going to be removed by dialysis. Okay? So generally, diffusion is going to remove the low molecular weight drugs. And then convection, because of that pressure gradient, it's going to remove the middle and low. And then I would say when you're using the high flux membrane, it's going to be middle weight to low weight as well. Protein binding, many drugs are bound to albumin and alpha-1 acetylglycoprotein, okay? So this is easily information to obtain. Where would you obtain this information, whether a drug is bound to albumin or alpha-1 acetylglycoprotein? Lexicomp is a great resource. What else? Micromedics. What else? Package insert, the product insert, right? But Micromedics, do you guys have access to Micromedics? You do?
Yeah.
I should figure out how. Lexicomp is a great resource. Those should give you protein binding, okay? If it's highly bound to to proteins, it's probably not going to be pulled off. So drugs with greater than 90% are less likely to be dialyzed. Drugs with a low protein binding are more likely to be dialyzed. Remember, in renal impairment, protein binding changes, right? Especially albumin. So in chronic kidney disease, they generally have a lower albumin than a normal patient. So their amount of free drug is going to be higher than a normal patient. Does that make sense? So if you have a normal or a low albumin compared to a patient with a normal albumin, the patient with a low albumin is going to have a higher free drug available in a protein-bound drug. So in that case, you may be able to pull off a little bit more than the normal patient. Alpha-1 acetylglycoprotein is usually an acute phase protein and usually increased in stress in the critically ill. So it would be conversely with albumin. This is just a chart that is an example that shows you a variety of different drugs, their percent protein binding. So again, anything above 90, it's probably not going to be dialyzed that much. Phenobarb has a protein binding of about 50%, so you're going to be able to pull off some phenobarb. That's free drug in the serum. Lithium, I mentioned, is dialyzable. That has zero protein binding basically. So most of lithium is going to be in the serum, and you should be able to pull that off readily. So if you have a patient coming in with a lithium overdose, one of the treatments is to dialyze the patient. Vancomycin, it's variable depending on the membrane type. Remember, the high flux membranes will pull off vancomycin to a great extent. Atenolol, one of the only beta blockers that is more soluble and less lipophilic, so that can be pulled off fairly good. A lot of the antibiotics are dialyzed off. Okay, you have to make sure and look at their molecular weight, their protein binding, the lipophilicity, but a lot are. So those are highly impacted in dialysis patients. Levetiracetam or Keppra, linezolid, and triamterene can be pulled off.
Is it FYI or?
This is FYI. Yep.
Quick question.
Yes.
For if a patient is given any of those highly will you hold treatment before dialysis or
Great question. Yes.
hold treatment?
So we'll talk about that.
Oh, okay.
Yep. So these tables, FYI, I want you to know concepts, okay? If I give you a question, this drug is 99% protein bound. Is it going to be pulled off by dialysis? The answer is what?
No.
No. Okay, basic question. This drug is 200,000 Daltons. Is it going to be pulled off by dialysis? No. Okay, concepts. Volume distribution. Generally, small volume distribution drugs will be more pulled off by dialysis. It's going to be more likely to find that drug in the intravascular volume, in the blood. Moderate, it depends. Large, generally not, okay? And I would say greater than 2 liters per kilo here. So that's...
hypophilic? Large volume, I had to think about them as hypophilic?
Lipophilic, yes.
Lipo.
Yep, lipophilic or lipophilic, either one. If I tell you this drug is lipophilic, is it going to be pulled off by dialysis? No. All right, so general concepts. Just some examples. So again, low lipophilic drugs up here, gabapentin, levetiracetam again, cefepime. Those are all low lipophilic. Those are going to be mainly in the blood or serum. You're going to be able to pull those off fairly well. Vancomycin, it's a moderate size drug, and it's also moderate lipophilicity. So it's not going to be pulled off as much as some of the other antibiotics. Same with the Dialysisand. Digoxin, very high volume distribution. It's not going to be pulled off. You're not going to dialyze the patient with digoxin toxicity. Same with amiodarone, right? You probably remember that it has a very large, extremely large volume distribution. Once you stop taking the drug, it's going to be in the body for weeks. That's not going to be pulled off by dialysis. Okay, so you have to know those 3 factors. What are the drug-related factors? Volume of distribution, protein binding, molecular weight. Okay, if you understand those 3 concepts, I think you're going to be great. Okay? All right, so let's see if you understand them. High flux dialysis membranes enhance the clearance of which type of solute?
C.
1 for C. Does anyone agree with? Yeah, couple for C. Yes, middle molecules. So certainly, it's not going to be small only, right? With the high flux, you're going to be able to pull off small and medium molecular weight molecules. Vancomycin is a medium weight molecule. you're going to be able to pull it off with high flux membrane, okay? Which of the following drug characteristics most significantly reduces its removal during hemodialysis? So low molecular weight, high water solubility, high protein binding, or small volume distribution?
C.
High protein binding, right? As far as this. So high protein bound drugs are not going to be able to pass through that semi-permeable membrane because they're bound to the albumin or alpha-1 acid glycoprotein. A drug with large volume distribution is likely to be more efficiently removed, remain mostly in the bloodstream, accumulate in tissues, and poorly dialysable. C.
Where is C?
Okay, large volume distribution is going to be all over the body, in the lipid stores, skeletal muscle, less likely going to be in the serum or the blood, and that makes it less likely that it's going to be dialyzed. If you remember, like whatever is in the serum and blood, as long as it's not protein bound, is going to be pulled off by dialysis. I think that's a good way to remember it. So those concepts are very important. Molecular weight, volume distribution, protein binding. Because if you don't have primary literature to guide you, you can make a clinical decision whether it's not going to be pulled off or not. Okay? So that's going to help you. Luckily, in 2025, we have a ton of literature available, primary literature. We have a tertiary resources, micromedics, Lexicomp that we can go to. So that helps us out quite a bit. But this is my stepwise approach. So when I'm approaching some patient and I'm deciding whether or not I need to adjust that medication because they're on dialysis, this is kind of what I go through. Okay, step one, you collect history and pertinent information. So you do that in every patient, right? You need to know why they're there, their demographics, blood pressure, labs, et cetera. Assess the drug-related factors that we said, molecular weight, protein binding, and volume distribution. The patient-related factors, their albumin, fluid status, blood pressure. The dialysis-related factors. So that dialysis prescription, so the type of filter, whether it's high flux or not, the membrane type, semi-synthetic or conventional. Commonly, it's going to be semi-synthetic nowadays. The flow rate, the higher flow rate, the more efficient it's going to be pulled off. Duration of the dialysis, so is it intermittent, only 3 to 4 hours versus continuous? Continuous is probably going to be a little bit more efficient, right? Because it's 24 hours a day. And then assess the current medications. So you can do this by looking at those drug-related factors. You can look at tertiary care literature, information databases like Lexicomp, Micromedics, and look at the renal dosing section. And if you can't find it there, then you're going to have to go to the primary lit. I would say that as far as the tertiary care databases, Lexicomp is by far the superior for renal dosing medications and the content that they provide for renal dosing. The work that they're doing is fantastic. So they've done a ton of work in this area. And as far as really putting together specific recommendations on degrees of renal failure, dialysis, whether it's intermittent dialysis, CRT, peritoneal dialysis, et cetera, they are doing excellent work. And I know the pharmacist doing it. She's doing a fantastic job. So I would use Lexicomp over Micromedics. That's my opinion. Plan individualized treatment regimen, right? You want to do this with every patient, but determine the adjustments per therapeutic goals and therapeutic drug monitoring. Estimate drug removal and need for supplemental dosing. So that question was, do you administer the drug after dialysis or before? We'll get to that. Use appropriate drug information resources like Lexicomp. Use primary literature if needed. So timing of drug administration, pre-hemodialysis. So you want to avoid this in drugs that are removed by dialysis, right? You don't want to give the drug right before dialysis if it's just going to be removed. Post-hemodialysis would be used for drugs that are going to be removed. So such as aminoglycosides, vancomycin, some of the cephalosporins you're going to administer after dialysis. Sometimes you might need a supplemental dose to replace the drug that is lost through dialysis. So we're going to talk about that. And then step 7, 8, follow-up would be monitoring, evaluate your monitored drug response, monitor drug levels as needed, etc. You don't have to know these stepwise approach. It's there for your information. This table is a small list of drug classes and whether or not they're dialysable or not. Again, this is only for your information. I would go directly to the drug information literature or databases to get this information, okay? But this is just gives you a general guideline of what, if it's dialyzed or not, and what you would do. Hemodialysis. So we're going to start with hemodialysis. So remember, drug clearance is dependent on the mode of dialysis, the schedule of dialysis, the filter that they use, and the flow rates. Unfortunately, if you go to the primary lit, most studies aren't going to describe all these factors. So they may tell you the filter, they may tell you the duration, they may or may not tell you the flow rate. So it really depends. I would say in 2025, it's getting a little bit better and that it's more likely to find this information than like 1990s, but you might not have this information described in the primary literature. So to be able to take that primary lit and apply it to your own patient, your individual patient, may be very difficult to do because it's not going to be exact replica of the study. So I would say start with tertiary drug references like Lexicon. I would start there first. They provide dose adjustment guidance for many medications, and it's growing every day. And then evaluate each patient individually. Evaluate those drug-related factors like I mentioned, patient-related factors, and the dialysis-related factors. And if you can't find it in the tertiary drug reference, then review the primary lit. So remember that you should be, sorry, my voice is gone. You should be fairly familiar with some drugs that are readily dialysable or not. And over time, you'll gain this experience. And then you'll be able to say, yes, this patient's on cefepime. I need to know that I need to renally adjust this based on dialysis, and this is where I'm going. But that just takes time. Loading doses, depending on the drug, may not need to be adjusted. Loading dose is what? Why do you give a loading dose?
Most rapidly move the.
So I think I'm hearing to get it to therapeutic range, right? As fast as possible. So sometimes you want to do that. And even if they have renal failure, you might give a normal loading dose, especially with antibiotics. So you have to be careful and not to underdose the patient. If you can do therapeutic drug monitoring, I think I would. So if your patient is on aminoglycoside, if your patient is on vancomycin, we can readily get levels of those drugs. I would get those drug levels and individualize treatment. You want to factor in non-renal clearance whenever possible. not 100% of drug is going to be removed by the kidneys, right? In some cases. Some drugs have non-renal clearance, so either hepatic clearance or other methods of clearance. So you have to factor into that as well. Consider supplemental doses after dialysis for drugs significantly removed by dialysis. And then be careful not to underdose, like I mentioned. So for drugs with significant removal post-dialysis, so these would be drugs like aminoglycosides, vancomycin, in this case is Keppra. You would probably administer a supplemental dose. So ideally, you would draw a level post-dialysis, see what the level is, and then assess how much dose you would have to give to get them to back to where you want the patient to be. So for in this case, Keppra or levetiracetam is about 30 to 40% removed by dialysis, 50% removed by dialysis. So you would use usual dose times a fraction removed. So usual dose is what in this case is 1,000 milligrams times 50%. So that would be your supplemental dose. So you're just subtracting out the dose that is removed by dialysis, the fraction that's removed by dialysis. That's if you don't have levels. If you have levels like aminoglycosides, vancomycin, I'd pull a level and do some math. So this is just general concept, okay? This shows you in a graph. So your concentration of drug there, you have the dialysis period, it's probably intermittent dialysis, and it goes down fairly low. And then you would use the supplemental dose to get it above the therapeutic range. Again, the timing of drug administration is important. So pre-drug, pre-dialysis is, you can use that for drugs that are not readily removed by dialysis. Post-dialysis would be the drugs that are going to be removed by dialysis. And then during dialysis for drugs when time-dependent activity or continuous infusion is needed. So it doesn't matter when to administer that drug. But the best point that you need to know is if it's going to be removed by dialysis, generally give it after dialysis. You want to watch for accumulation of active drug and metabolites. So you need to know some basic understanding. Does the drug have active metabolites? And can they accumulate based on those drug-specific factors? Adjust based on clinical response, right? We're always going off a clinical response and not just a lab value. Regularly review medications. So medications change all the time. You'll be just surprised, like when you go in the hospitalized setting, these patients may have from 5 to 15 different drugs on their profile. It's a lot of drugs, right? So you have to go individually, one by one, and say, is this one going to be affected by dialysis? Then go on to the next one. So we'll review every one that the patient is getting. Monitor for improvement in renal function. That's very important because as the patient's renal function improves, they may be producing urine. So they can have renal losses of drug in addition to that loss that's coming through dialysate. And then the hemodialysis prescription can change. So maybe they stop it one day, and that will affect whether or not the dose you give is appropriate or not, right? So if they're not being dialyzed for whatever reason, it could be hypotension, infection, whatever, then you're going to have to definitely readjust that drug. So things are dynamic, and they'll change all the time. CRRT dosing considerations. Know that loading doses generally do not require adjustment. If it's pulled off by CRT, you may have to increase the dose. So use a dose much higher than you would in normal dialysis. So hemodialysis, because it's continuous, it's being pulled off for generally 24 hours a day. We have a lot of limited data in CRT. So it's very difficult to do these studies. Again, it's not going to be as applicable to your own individual patient because all the nuances that they did in the study. So it's hard to extrapolate that to your patient. So you can use primary literature, but it's going to be very difficult to translate translate to our patients. So I would use more tertiary references initially. So always start there, okay? Again, use therapeutic drug monitoring to guide adjustments when possible. Remember the differences between the CRTs. So CVH is convection. CVHD is diffusion. CVHDF is both convection and diffusion. So those are going to dramatically influence how much drug is being pulled off in your patient. So in this case, your dose of drug, if it's going to be dialyzed off, is much higher than in convection. Peritoneal dialysis, generally drug is removed at a much lower extent than hemodialysis. So peritoneal dialysis is not as efficient in removing drug. Remember, it uses your peritoneum to get rid of the waste product or the drug, right? So you're not using the patient's blood. In general, dosing recommendations are typically based on a creatinine clearance of less than 15. So you can use that as a kind of rough guidance to dose medications, but I would always look it up in the tertiary literature. For drugs that are dialyzed, just like hemodialysis, generally administer after peritoneal dialysis sessions. So it doesn't make sense to administer it before or during, with the exception of infective peritonitis. The membrane characteristics will influence drug removal. This is just FYI. The larger pores will pull off some more drug, but most of them are going to be the smaller pore with the membrane. So removal is significant removal for peritoneal dialysis is for very low volume distribution drugs, low protein binding, and low non-renal elimination. You're going to have more drug removed if you have those three situations. So therapeutic drug monitoring. In hemodialysis, would measure drug levels before and after dialysis. That's going to give you how much is being removed during dialysis. And that's going to help you decide how much of a supplemental dose to give. For peritoneal dialysis, you would monitor levels at random times, depending on the specific drug, of course. And then continuous renal replacement therapy. Most of the time, it's random intervals because the continuous dialysis is 24 hours a day, so you can get the level anytime you want, generally. So this is a post-dialysis example. And what I want to point out is that there's a 4 to 6 hour window of distribution phase after hemodialysis. So that's a period of time where all that fluid is kind of being equilibrized within the body. So if you immediately take a level here, it may be far different than when you take the level farther out after the dialysis. So just be aware of that, is that your levels can fluctuate based on the the fluid level fluctuating within the body. Remember, you're taking this from the serum. So after you do hemodialysis, all that fluid that's in the interstitial space over time is going to be equalized to the intervascular space. So there can be some differences in concentrations following hemodialysis. So generally, you don't want to do immediate post-hemodialysis. Wait several hours if you can. So for hemodialysis, again, for therapeutic drug monitoring, you want to measure concentration prior and after hemodialysis, and that will estimate the amount of drug removed. You can determine that post-hemodialysis concentration, then calculate a supplemental dose. This is very common with aminoglycosides. In this example, it's vancomycin. So you have a pre-hemodialysis concentration of 22. About 40% is removed, and you have a post-hemodialysis concentration of 13. So you can do some math and pharmacokinetic equations to give you a dose to target a level of 15 to 20. When did you guys have pharmacokinetics?
Already done.
Done?
Yeah, last year.
Do you have it next year?
No.
No, you're done with it. So did you do all these equations?
Something like that.
It's fun stuff. All right. Which? Do you have a question?
Yeah, I'm looking at the recommended dose.
So this is just an example, okay?
Just an example.
Yeah. What I would do is do those calculations on your individual patient, because your individual patient is going to have their own volume distribution. That's going to affect what dose that you're going to give. Okay. So which of the following drugs is least likely to be removed by dialysis?
List.
Wait.
Why digoxin?
780. 780 Daltons.
High protein, diabetes, large.
Look at that volume. Okay.
Is high. The weight is also high. Molecular weight and the volume is
That's not that high though, right?
but it's bigger than 500.
So volume is certainly way higher than the others, right? This is going to be in the serum. That's going to be in the serum. And that one, lithium, certainly will be in the serum. So it's really based on these profiles that volume distribution is driving this to be less likely than the other drugs to be dialyzed off. Which drug is most likely to require supplemental dose after dialysis? Gabapentin? Does everyone agree? Why is that?
Molecular weight is low, volume of distribution is low, protein binding is low, so it's just going to get out of the system.
So it will be dialyzed, and if it will be dialyzed, you're more likely going to need a supplemental dose, right? Good. So this is erythropoietin. Look at that molecular weight. That's very high, less likely.
Not going anywhere.
Warfarin, protein binding, 99%.
Not
That's
going anywhere.
amiodarone, very high volume distribution and protein binding. You're probably going to get a question like this, okay? Drug removal and dialysis summary. Look this over. I think this gives you a good summary on the different modes of dialysis and drug removal. But I'm going to go over this case real quick.
Dr. Gonzalez, can I see the other question, the first one? The Dialysisand. Yeah. Thank you.
Okay. Case. So this is a MR, is a 62-year-old male, admitted to the hospital with severe peritonitis. He currently is receiving antibiotics and has a history of pseudomonal infection. Urine output is less than 500 mils per day. He has type 2 diabetes, hypertension, CKD stage 5, peripheral vascular disease. He's on continuous ambulatory peritoneal dialysis, okay? And he's receiving piperacillin, tazobactam, vancomycin, labetalol, heparin, and insulin. So what I would do as a clinical pharmacist is know that he's in the hospital, he's receiving antibiotics, he's on CAPD. I would look up all these medications that are on his profile to determine if he needs, those medications need to be adjusted for peritoneal dialysis. Okay? So in this case, I used Lexicomp and looked up piperacillin, tazobactam, and it lists peritoneal dialysis. 6% of piperacillin is dialyzed off, not much. 21% of tazobactam, again, not a lot, but this is their recommendation. So 4.45 grams every 12 hours or 2.25 grams every 8 hours. So you could choose either one of those. And how I would choose it is based on the patient factors. But they give you a pretty specific recommendation to use in peritoneal dialysis. For vancomycin, we're not going to talk about oral. So loading dose, they recommend 20 to 25 mg per kg. General loading dose in the critically ill will be closer to 30 milligrams per kilogram. And then they say vancomycin serum concentration should be obtained 2 to 3 hours, 48 hours, 72 hours after loading dose and subsequent doses. And then usually 10 to 15 mg per kg should be administered based on attainment of goal. So they give you some idea of what to do as a clinician. For labetalol, peritoneal dialysis, it's poorly dialyzed and no dosage adjustment necessary. Then for insulin, because the molecular weight of 6,000 Daltons, and I believe it's protein bound, insulin is not significantly removed by peritoneal dialysis. So you don't need a supplemental dose. So it gives you some great information to start with, right? Now, if it said there's no data, then you would have to look at the drug-specific factors, look at the primary literature. But if it's not in Lexi, there's probably no primary literature. So same patient, now he developed septic shock and is admitted to the ICU requiring CRRT. He's still on piperacillin, tazobactam, vancomycin, heparin, and insulin, and the labetalol is discontinued because he's in septic shock. You don't give a beta blocker in septic shock. So yeah, it has CRT with a high flux filter. Remember the high flux. So piperacillin, tazobactam gives you a whole bunch of information here. Drug clearance is dependent on effluent flow rate, so a dialysis-related factor, the flow rate, method of renal replacement, CRT, of course. Recommendations assume a high flux dialyzer and effluent rates of 20 to 25 mils per kilo per hour. So you can find that based in the patient's chart or the renal note. Appropriate dosing requires consideration of adequate drug concentrations and site of infection. So you have to take into account those patient-related factors, the site of infection where you're treating the patient. And with antibiotics, you definitely want to maintain adequate concentrations at the site of infection. Consider loading doses, initial loading doses. So what do you do? Read through this stuff, and then for piperacillin tazobactam, 4.5 grams every 8 hours, or a 4.5 gram loading dose followed by a 2.25 every 6 hours. And I would choose between those based on where the infection is and the clinical status of the patient. They even give you continuous infusion data if you go that method. Vancomycin, again, it tells you some information about the high flux dialyzer and the flow rate. And the reason why they pick these flow rates is that's the more typical flow rates used in clinical practice right now. But you always have to check with your nephrology people. So with vancomycin, a loading dose of 20 to 25, and then 7.5 to 10 milligrams per kilogram every 12 hours with frequent serum concentration monitoring. So you're going to do TDM with vancomycin. Insulin administers about 75% of normal dose. So with CRT with the high flux filter, that is going to pull off some insulin, but not a lot of it. So the dose is 75% of normal dose. All right, patient improves and gets discharged on intermittent dialysis. So he's no longer on hemodialysis. And then he's still on piperacillin, tazobactam, vancomycin, labetalol, and insulin. So piperacillin, tazobactam from hemodialysis. This gives you intermittent 3 times weekly recommendation. Tells you it's 30 to 40% dialyzed off, and a recommendation for the dose. It says administer scheduled doses after dialysis. It's going to be pulled off by dialysis, and that's preferred but not required. Vancomycin is a little bit harder to get through, but basically, if the dose is given after dialysis, you go here. If the dose is given during dialysis, you go here. So in intermittent dialysis, they can administer a lot of drugs in that session of dialysis. So sometimes they'll do that in patients so they don't have to get a drug administered at home. But if you give it after dialysis and you have a low flux filter, you give this dose. If you have a high flux filter, you give this dose. You can see the loading dose is the same, 25 milligrams per kilogram, but the maintenance dose is different because the high flux filter is pulling off more drug. Labetalol is not dialyzed, so no supplemental dose is needed or dose adjustment is needed. And then insulin, large molecular weight, and it's not significantly removed by hemodialysis. So that's kind of the steps I use, okay? Certainly Lexicon's not going to be on the exam, so I want you to know concepts. Know concepts of the different types of ways to pull off drugs, so diffusion versus convection. Those are important. Know those drug-related factors, molecular weight, volume distribution, and protein binding. Know some dialysis-related factors, so flow rate, high flux, membrane, etc. Any questions? Review the learning objectives, please. That's a great start to get you to know this material. All right. Thank you. We'll have a picture. This is Iceland. Iceland. Have a great day, guys.